We are the Association for Child and Adolescent Mental Health, or ACAMH for short.
Hello, welcome to the Papers podcast series for the Association for Child and Adolescent Mental Health, or ACAMH for short. I'm Jo Carlo, a freelance journalist with a specialism in psychology. In this series, we speak to authors of papers published in one of ACAMH's 3 journals. These are the Journal of Child Psychology and Psychiatry, commonly known as JCPP, the Child and Adolescent Mental Health, known as CAMH, and JCPP Advances. Today I'm interviewing Dr. Isabel Morales, Assistant Professor in Psychology, based at the Institute for Mental Health, School of Psychology, University of Birmingham. Isabel is an author of the JCPP paper, Shorter Nighttime Sleep Duration and Later Sleep Timing from Infancy to Adolescence. This paper will be the focus of today's podcast. If you're a fan of our Papers podcast series, please subscribe on your preferred streaming platform. Let us know how we did with a rating or review, and do share with friends and colleagues. Isabel, thank you for joining me. Welcome. Can you start with an introduction about who you are and what you do?
Yes, so thank you very much, Jo, for a very kind introduction. So as you mentioned, I'm assistant professor at the Institute for Mental Health, that is part of the School of Psychology at the University of Birmingham. And so my main research is actually focused in sleep and how sleep relates to mental health problems. More specifically, is trying to understand whether sleep problems happening in early stages of life, whether that can constitute a risk factor for developing mental health problems in the future stages of life.
Thank you. So today we are going to look at your paper, Shorter Nighttime Sleep Duration and Later Sleep Timing from Infancy to Adolescence, recently published in the JCPP. Before we go into the detail of the paper, Isabel, can you define poor sleep health? What are the hallmarks of poor sleep health?
First, to clarify, so in this specific study, so actually we used the term of poor sleep health, kind of an equivalent to what it would be sleep problems, but the specific concern that we had in this study is that actually we were not able to categorize these as sleep problems, as actually there was not a specific measure within the questionnaire that asked the parents or the children whether actually this constitute a problem per se. And that is where actually we decided to use the term poor sleep health. So this is a term that was defined some years ago by Professor Daniel Buisse, that he is one of the most renowned experts in the field of sleep. And so this term, sleep health, is defined as a multidimensional pattern of sleep wakefulness adapted to individual, social, and environmental demands that promotes physical and mental well-being. It could be similar to concept of sleep quality, but emphasizing that this actually has an impact on the health and well-being of the individual. In our specific case, so it's referring to these specific sleep health dimensions of sleep duration and sleep timing, which are aspects of this wider sleep health or sleep patterns, so further sometimes to the sleep quality or further than insomnia symptoms. Yeah.
Great, thank you. Your paper detects trajectories of persistent poor sleep health. Can you tell us what is a typical trajectory for sleep duration and sleep timing from 6 months to 16 years of age?
Yeah, so actually this is a very good question. It is not that I can give an straight. Actually, the sleep patterns of a specific group actually will depend on the specific population that you are measuring that. Also, it might differ depending in which specific country, or even sometimes depending on the specific season. So taking into consideration these features, actually what we present in this study is the trajectories, and in that sense, so it's true that we detected a specific trajectory that refers more to these normative patterns, but actually this refers to the specific large population sample that were recruited in the UK, but in a specific area, which was the Avon area, within the 90s age range, so also like because we know that actually sleep duration is something that is becoming shorter over the years, and also children, because of the societal demands. We know that children, and anyways, like all of us, we tend to go more and more often later to bed. So just taking into consideration the location and a specific year that this data was collected. So then this true that anyways, we were able to detect some normative patterns within that very large sample size. It is quite representative, taking into consideration those restrictions. So what we saw in terms of the sleep duration, so what we could consider is a normative pattern, is that at the age of 6 months, so the amount of time that the children sleep at night is around an average of 10 hours. Then this increased to 10 hours and a half to 11 hours from the age of 18 months to 7 years old. And then we start decreasing the amount of hours of sleep slowly from the age of 9 to 11 years. So it's decreased over 1 hour. So in our data, we have that between the ages of 9 to 11 years old, the children tend to sleep around 10 hours at night. And then it is true that we saw a considerable decrease of sleep duration at the age of 15 years old in our data, which anyways, this is consistent with what we know in terms of sleep duration in adolescents. So within our data, so a normative pattern of sleep duration was around 8 hours and a half. And then in terms of the sleep timing, so sleep timing differs usually to the time that the child goes to sleep. And so in that sense, we found that in average, so the normative trajectory, it was that from the age of 6 months to 6 years, it was around 8 p.m. At the age of 15 years old, we found in our data that the average is around 11 p.m.
Excellent. So let's get into the details of the paper itself. Can you start with an overview? What did you look at and why?
So in this study, what we explored were the trajectories of nighttime sleep duration and also the sleep timing. The sleep timing in this case was measured with two specific variables. One was the bedtime, and the other one, it was a measure that we created that is called the midpoint of nighttime sleep. So it's similar to bedtime, and actually midpoint of nighttime sleep is a measure that is used to indirectly study the chronotype. So the chronotype, it is like the preferred time of the individual, for example, that they may go to sleep or that they may be more active for specific tasks. So we use midpoint of sleep as an indirect measure of chronotype, which actually the midpoint of sleep is the clock time between the sleep onset, but also the wake up time. Sometimes bedtime also is used as an indirect measure of chronotype. But if you don't take into consideration what time the child goes to sleep, so then actually we are not actually exploring whether this might have a clear impact in that sense. So the midpoint of sleep, it is more accurate measure of chronotype. Yes, sorry. So in that sense, what we explored were these three main trajectories. So one trajectory of nighttime sleep duration, a trajectory of bedtime, and separately another trajectory of midpoint of sleep. So we had data from children since the age of 6 months until the age of 15 years old. So actually, there is so far not any study that in the UK actually explores in detail these specific trajectories. Sleep duration, there is a bit more studies that try to explore that, but also considering the important factor of the chronotype. So also how the chronotype develops from infancy to adolescence. And I guess one other focus that we were very interested in this study, so we were, of course, exploring the different trajectories, but we had a very clear focus. We were interested in those specific trajectories that detect those individuals that present persistent or chronic sleep problems. So we know sleep is something that develops, and there is a lot of variability in terms of the sleep across childhood. There might be children that may sleep poorly at the age of 6 months, but then they might improve their sleep, and then at the age of 1 year old, they might be considered good sleepers, right? So then what we were actually interested is what happens in those children that present sleep problems persistently since infancy to adolescence, based on our hypothesis that actually these are the children that are at highest risk of a number of adverse outcomes.
I want to look at the findings in a moment, but before we do that, can you say a little bit more about the methodology that you used?
This study is what we call a secondary data analysis study. So we did not conduct our own data, but we use an existing data set from the UK. So this is a very widely used and validated longitudinal cohort study. So this is the ALSPAC cohort, also known as the children of the 90s, that refers to Avon longitudinal study of pregnancy and childhood. As I mentioned earlier, this was a study started in the 90s, recruited around 14,000 women during pregnancy. They have been followed up since the 19s, so the parents and the children until currently. So now those children, they are around 30 years old, and actually now there is the children of the children. So there are people that continue involved in this study. So it's an amazing resource that continues growing. For this specific study, so we selected those sleep variables that were from 6 months until the age of 11 years old. And then at the age of 15 years old, the information that we had was self-reported by the adolescent in that case. The variables that we used was nighttime sleep duration, bedtimes, and then we created variable of midpoint of sleep. And in addition to that, we were interested to detect the trajectories of sleep. So the second part of the study was actually to detect whether there are any key relevant early life risk factors that happen before the age of 6 months that would lead to the development of persistent sleep health conditions over time, right? So in that sense, specifically with the data, right, it would be whether there are specific early life risk factors for persistent shorter sleep, or whether early life risk factors for persistent later bedtime, or for persistent later midpoint of sleep. These are the three trajectories that we would consider that this is the poor sleep health, as we call in this paper. So in terms of the early life risk factors, so we selected a range of pregnancy or very early life potential risk factors, which were the sex of the child, ethnicity, birth weight, gestational age, health and temperament, all about the child, and also some risk factors from the mother, such as mother's adversity factors happening during pregnancy, age of the mother at the birth of the child, socioeconomic status of the mother, and also postnatal anxiety and depression. These factors were chosen based on existing evidence that these are actually relevant factors for sleep problems.
Isabel, what key findings from the paper would you like to highlight?
We were able to detect the different trajectories of sleep duration, also bedtime and midpoint of sleep over time. So I'm highlighting that this is a key finding, because sometimes when we use data about the sleep, considering that sleep is so variable between subjects, but also within the same subject, sometimes it is not possible to actually detect specific trajectories, relevant groups of children over time, because we are trying to categorize the groups from infancy, so considering very large time range, so from infancy to adolescence. So actually that was kind of one key finding, that actually we were able to detect those trajectories as happening. And importantly, so we were able to detect, although a small, but small, I think, is what is representative of the general population. So we were able to detect a small group of children that actually present with persistent sleep problems since infancy to adolescence. So that was kind of one of the main key findings. And the second key finding is that when we test the associations between the early life risk factors and the three main domains of poor sleep health, We found that there were different early life risk factors that were associated depending on the outcome. But overall, actually, we found that there were two main risk factors that were associated with the three main sleep domains. So these were early life family adversity. So basically, this refers to adversity conditions of the mom during pregnancy, and also lower maternal socioeconomic status. So those two, which we know this refers to adversities and to poor conditions of the life environment of the child in that sense. These actually were the most relevant risk factors for developing persistent poor sleep in childhood.
I want to return to that in a moment around the adversity and low socioeconomic status of the mother. But I want to sort of drill in a bit onto persistent shorter sleep and also the impact of later chronotype. So your paper states that persistent shorter sleep potentially constitutes the group at highest risk of developing adverse outcomes. Can you elaborate on how and why this is?
So, I mean, of course, to be fair, this is something that still we need further understanding of this, but I can just provide some explanation based on we won't know already. So one of the potential explanation is because actually there is a cumulative effect of the poor sleep that is happening. So if it's only happening at specific stage, but then there is good sleep at the other stage, so actually, in that sense, it can be restorative, then it might have a less severe impact. But if we are considering that in these cases, so a child with persistent poor sleep, it means that at all the different stages, so there is no rest in that sense of the effect that the poor sleep is having, especially in the impact on the brain, is something that we need to explore further. But one of the hypotheses behind is, so the brain is, of course, like childhood and adolescent are critical stages for the brain development. And we know that sleep has an impact in the brain development, especially at these critical stages. So if there is consistent poor sleep, consecutive and a cumulative impact on the brain, that consequently this will put the child at highest risk of wide range of aspects, such as in my research, I focus in how this could link to mental health problems. Actually, this is supported by some of our research that we have been done in parallel. So we have found that actually persistent shorter sleep in children is a risk factor for developing psychosis in young adulthood, while there is not that much evidence that sleep at a specific stages, it is a risk factor in that sense, is the poor sleep. And finally, I guess to highlight that this actually mimics the experimental designs that there have been for many years in terms of sleep deprivation is a well-known paradigm to induce psychotic symptoms. There are many studies that in order to test the causality of sleep, so there is any evidence suggesting that depriving sleep in healthy individuals for 2-3 consecutive days actually leads to the development of psychotic symptoms in these healthy individuals compared to those that do not experience these sleep deprivation conditions.
So I have a similar question around later chronotype, because previous studies suggest later chronotype is associated with reduced school performance, increased mental health problems, and sleep problems. What is it about later chronotype that puts children at greater risk?
Again, so this is a great question. The thing with chronotype, we know quite little compared to sleep duration, for example, especially in childhood. So this, again, I need just to highlight that we need further understanding of what the role of chronotype it is, especially in younger population. When people start talking about the sleep problems, we tend to forget also about the chronotype, circadian rhythms, and they are quite highly related to each other. That's what actually we do not have, I guess, much evidence of the mechanisms why this will link. But having said that, one of the main explanations here, it could be some people are with are actually a late chronotype per se compared to an earlier chronotype. It might not be a good or bad thing. I guess the problem that we find currently is the society that we are living in. And so basically what happens with the children is that they might have born with a late chronotype, some things that we just cannot change. There are some therapies, but still, I guess the debate is there, right? Whether it has to be changed or not. But I guess the thing is like the child is born in a society that you need to wake up at a specific time, especially during school days. So every child needs to wake up at the same time. And currently we are tending the society to wake up earlier and earlier because the society has higher demands, right? So then actually with this kind of simple explanation, already we could see that a child has later chronotype, that if you have a later chronotype, you are going to bed later. Otherwise, you are not going to fall asleep, or you are going actually to say I have insomnia symptoms because I don't fall asleep at certain time. But yeah, because your chronotype is later, and maybe this is not the time for you to go to sleep. But then if they may go to sleep, for instance, 1 hour later than a person that has an earlier chronotype, then both of them probably they will wake up at the same time, because this is established not by your internal clock, that usually the person that is later chronotype also wakes up later. So at the end, the sleep needs tend to be quite similar between each other. So in that sense, those with later chronotype have later bedtime, but wake up at the same time. What happens? They have shorter sleep duration.
Right. So is it possible that the increased mental health problems that are associated with later chronotype might not exist if adolescents were allowed to get up at their individual preference and go to sleep at times that suit them?
That's something that there is one idea behind that. I think there have been actually several initiatives. I think maybe you're aware about this delaying the school start times, with these ideas behind that. But of course, we understand that this is not possible for the society as a whole, because then the parents will be complaining. So it is quite a complicated reality.
I want to turn to the finding that you highlighted earlier. So this is that family adversity and lower maternal socioeconomic status during pregnancy were associated with poor sleep health from infancy to adolescence. Can you elaborate on why this might be?
So the family adversities index that we used in the ALSPAC, actually it covers a wide range of conditions that we know that affects the life in that sense of the mom during pregnancy. There are things like poor housing conditions, poverty, against problem with economic difficulties that relates, of course, to socioeconomic status. So I guess a very wide range of adversities, like childhood adversities that we know have an impact. And so I guess in that sense of both things of family adversities and lower socioeconomic status, this refers to the poor environmental conditions that we know that actually there is kind of more and more evidence suggesting that actually this has an impact in our health, but also this has an impact in the sleep of the child. So it is, I guess, quite complex in that sense, the system, but we know that, children from poorer socioeconomic backgrounds are at highest risk of a wide range of health outcomes. This is related, so in that sense, those from lower socioeconomic status are going to experience more sleep problems, but also those that are suffering from a wide range of early life adversities.
What are the implications of your findings for clinicians and CAMH professionals in terms of how patients are screened and in terms of treatments or interventions?
The measures that clinicians and other practitioners are working with children, are, for example, social workers. They should, for example, consider routinely screening for adverse childhood experiences, including also, of course, socioeconomic status. So I guess within those routinely collected measures, there should be like robust measures of socioeconomic status within the daily practice, and also to widely consider a wide range of potential early life adversities that would be detecting those children that might be at highest risk for mental health outcomes, because they are so highly linked to each other.
Given the association between family adversity, social economic status, and poor sleep that you mentioned before, what recommendations emerge from your research for policymakers?
So actually our results highlight the necessity to address inequalities in the health of infants in the UK. So we know that there are kind of like clear disadvantages in terms of the environment of where the child is born, and also in terms of the socioeconomic status, we know this has major impact in their life. So addressing these health inequalities is key, and also this follows some of the recently published recommendations by the Royal College of Pediatrics and Child Health that highlight the necessity of reducing health inequalities as a result of child poverty and adverse childhood experience.
Are you planning any follow-up research, or is there anything else in the pipeline that you would like to share with us?
We are really interested in this specific group of children that present persistent poor health, especially using this specific data set of the ALSPAC. So currently we are focusing in follow-up studies where we are trying to understand or explore the specific impact of these poor sleep health trajectories in the development of mental health outcomes. So as I mentioned earlier, so we recently published a study where we found that the persistent shorter sleep duration is a risk factor for psychosis in young people. And also we want to explore that similarly, whether this has an impact in the development of mood disorders, for example, such as depression or anxiety, and also not only to consider or the shorter sleep duration, but also to explore the impact of persistent late chronotype, I guess, to further understand, as we were saying earlier, right, whether actually that has an impact or not, or whether what is the mechanism, because maybe we try to see whether the sleep duration has an impact there, we could actually try to understand a bit more. But yeah, now we're trying to understand the specific impact of these sleep trajectories in the long term in these individuals.
Sounds really interesting. Isabel, finally, what is your take-home message for our listeners?
So the first one is like, it is very important to assess and further understand sleep. And then also, I guess sometimes when I explain my research to many people, then everybody gets sometimes afraid, say, you know, well, then they have a specific, I think all of us at certain stages of our life, we have experienced sleep problems. So that's something that, anyways, sleep problems, specific stages for different circumstances is something that it happens, it's normal, and does not necessarily need to have a direct impact in our daily life or in our future. But I guess what is important, what I wanted to highlight in this research is actually to detect those children that actually present with this persistent poor sleep over time. Because I guess all of us sometimes we have here the sentence of somebody saying, oh yeah, for all my life, I've been sleeping poorly. And we just assume that by default it's like a trait of ourselves. But then in those cases, it might be, well, I guess maybe that is something maybe we might not need to consider as, okay, it's part of myself, but maybe something that actually if you could do something to improve, maybe you might feel better, because then those people might start then considering things, yeah, I tend to always kind of to get ill more frequently. I tend to kind of have more depressive symptoms. Sometimes then we try to understand, okay, maybe the reason is behind something else. So I guess it's actually, you know, not to get alarmed by the fact that sometimes we all can have like poor sleep for different reasons, or the children, you know, there are developmental stages, but I guess it's just to pay special attention in those cases, that we see that the sleep problems persist over a consecutive period of time. And then the second take-home message is to highlight that there are a wide range of early life risk factors that actually can also lead to the development of sleep problems. So the same, it is not that sometimes we assume, oh, I was born like this, I just sleep poorly. And then most of the cases, actually, there are specific reasons behind why those sleep problems are happening. And in many cases, those are factors that can be. So I guess the positive message here is that sleep is something we can modify, and there are a wide range of sleep interventions that they work. It's much easier to modify in that sense that other more complicated behaviors or health-related aspects. And also not only sleep, the factors that affect the sleep, sometimes it can be the light, it can be the temperature, sometimes the specific factors that also are easier to modify can have an impact in sleep. So I guess it's trying also to give the positive message in that aspect.
Brilliant. Thank you ever so much. For more details on Dr. Isabel Morales, please visit the ACAM website, www.acam.org, and Twitter at ACAM. ACAM is spelled ACAMH. And don't forget to follow us on your preferred streaming platform. Let us know if you enjoyed the podcast with a rating or review, and do share with friends and colleagues.